So today, we're diving into a treatment that's, well, it's a real medical marvel, but it's also at the center of some really intense debate. I'm talking about intravenous immune globulin, or IVIG. This is a super powerful therapy made from the plasma of literally thousands of donors. And it sits right at this fascinating and kind of tricky crossroads between incredible medical hope and the cold, hard demand for proof. All right, so here's the roadmap for this explainer. We're going to start with why our bodies sometimes attack themselves. Then we'll look at IVG itself, this borrowed shield. We'll explore the off-label frontier, which is where things get really interesting. We'll meet the gatekeepers who decide who gets it, walk through a patient's journey, and wrap it all up with that central tension, hope versus hard data. Okay, first things first. Before we can really get into the solution, we've got to understand the problem. So let's talk about what happens when your body's own defense system just gets it all wrong. I mean, think about it. What if the very system designed to protect you, your body's own personal army, suddenly turned against you? That's not a sci-fi plot. It's the fundamental question behind a whole bunch of really tough diseases. Normally, that army is fighting off invaders, right? But sometimes, that army gets seriously confused. So you have these autoimmune diseases where your immune system becomes the aggressor. It's like friendly fire, attacking your own healthy tissues in conditions like lupus. But that's not the only way it can go wrong. The system can also be too weak. That's what we see in immunodeficiencies, where it just can't protect you from everyday infections. So whether it's overactive or underactive, the bottom line is the same. The immune system isn't working the way it should. So what do you do when a patient's own immune system just can't be trusted? Well, in a lot of cases, the answer is you borrow one. Now, this is super important. IVIG isn't some synthetic drug cooked up in a lab. It's a biological product. Think of it as a concentrated dose of healthy antibodies, all collected from the plasma of thousands and thousands of donors. It's quite literally a borrowed immune system in a bag, delivered right into a patient's veins. And the really amazing thing about IVIG is just how versatile it is. It's like a Swiss Army knife for the immune system. If a patient's system is too weak, IVIG provides the missing soldiers to fight infections. But if the system is overactive and attacking itself, it acts more like a diplomat. It calms everything down, blocks those rogue antibodies, and basically tells the inflammatory signals that are causing all the damage to just take a breath. Okay, and this is where our story takes a turn and gets really, really complex. You see, the officially approved uses for IVIG, that's just the tip of the iceberg. The real action, where most of it is used, is happening in this vast, uncharted territory we call the off-label frontier. So this brings us to a really critical distinction you have to understand. On-label use. That's when a drug is officially approved by regulators for a specific disease, after tons of large-scale trials. It's on the books. But off-label use. That's when a doctor uses their professional judgment and prescribes it for something else, something it's not officially approved for, based on their expertise and emerging science. The key difference is, it just doesn't have that same mountain of definitive evidence behind it. Yet. And here's the kicker. This is the absolute core of the issue. The vast majority of this precious, incredibly expensive resource is used in that gray area for off-label conditions. Doctors are on the front lines. They see it working for their patients, especially when other treatments have failed. But the big, large-scale scientific data just hasn't caught up yet. And that creates this huge challenge for healthcare systems everywhere. Who pays for hope? Which, of course, brings us to the gatekeepers. All around the world, there are these powerful organizations, and their whole job is to weigh the evidence and make the tough calls, deciding when an off-label use has enough proof behind it to be covered by insurance or a national health service. Let's start in Europe. You've got the European Medicines Agency, or EMA. They kind of set the baseline. They establish the official guidelines for what IVIG products actually are and what their approved on-label uses are. This creates a common framework that all the individual countries can then use to make their own coverage decisions. Over in the US, the big one is the Centers for Medicare and Medicaid Services, CMS. They're at the top of the food chain, really. Because CMS manages Medicare, their decisions about covering an off-label use of IVIG send these massive ripple effects through the entire system. What they decide often becomes the standard for private insurance companies, too, and that affects access for millions and millions of people. And then, if you zoom in, you get national bodies like Ireland's Health Service Executive, the HSE. What they do is create these super specific playbooks for doctors. They lay out exactly which conditions, say neurological ones, have enough hard evidence to justify using IVIG. The whole goal is to make sure this precious resource is being used where it's been proven to work best.
But here's the thing, these guidelines aren't set in stone. They can change. And this timeline for Susac syndrome, which is a really rare autoimmune disease, is a perfect example of that. So a formal request was submitted to CMS. They dug into the evidence, all the case studies and clinical observations, and they decided, you know what, there's enough here. So they officially expanded Medicare coverage for patients whose disease was refractory, meaning it wasn't responding to other treatments, or relapsing, where it kept coming back. It's a great look at how the system can evolve, how it can turn that clinical hope into actual official policy.
Now, it's easy to get lost in all these policies and acronyms, CMS, HSE, EMA, but we have to remember, behind all of this are real people, patients living with these incredibly complex diseases who are just trying to find the best care they can in a system that can be an absolute maze to navigate. I mean, we can talk about the high-level science all day, but for a patient with something like primary immunodeficiency, the challenges are much more immediate. Just finding a doctor who really understands your condition, who knows what IVIG is and how to manage it, that alone can be a monumental hurdle. And that's where advocacy groups like the Immune Deficiency Foundation are so important. They play this crucial role of empowering patients. They literally arm them with a list of the right questions to ask a new doctor. Smart questions like, do you take my insurance? How many people with my condition do you actually treat? And practical stuff about different brands or even doing infusions at home. It's about giving patients the tools to find the care that actually fits their life. All right, let's bring this all back to where we started, back to that central conflict. Because really, everything we've talked about, it all boils down to this one thing. This constant, really difficult balancing act between a doctor's hope for their patient on one side and the system's demand for definitive proof on the other. This table from those Irish HSE guidelines, it makes this tension crystal clear. Look at this. For a condition like Guillain-Barré syndrome, the evidence is solid, so IVIG is an approved use. Simple. But then you look at something like multiple sclerosis, and it's listed as exceptional use. That means it's only for severe cases where standard treatments have failed, all because the evidence is still just emerging. They've basically created official categories for how certain the science is. And for so many of these other conditions, the official word from gatekeepers like CMS is pretty blunt. This quote about systemic lupus says it all. They're basically saying, yeah, it looks promising, but we need more randomized controlled trials. Without more of those big, rigorous studies, they conclude that the evidence is just insufficient to justify paying for it for everyone. And underneath this entire debate is one simple, unavoidable fact. IVIG is an incredibly precious and limited resource. Get this, it can take more than 10,000 individual plasma donations to create just 1 year's supply for a single patient. 10,000! This isn't a pill you can just mass produce in a factory. It's a gift from thousands and thousands of generous donors. And that scarcity is what forces everyone to make these incredibly difficult choices. And that leaves us with this final, really challenging question. It kind of wraps up the whole debate, doesn't it? When you have a patient, a real person, sitting in an exam room, and they've got a rare disease with no other good options, how long should they have to wait for the data to catch up with their doctor's hope? It's a question that pits the rigorous demands of science right up against the urgent needs of humanity. And there are no easy answers to that one.